Hello, and welcome to this mini-gem brought to you by the Association for Elderly Medicine Education. My name is Henry Woodford, and in this mini-gem I'm going to talk to you about urinary incontinence in frail elderly people. By the end of this mini-gem, I hope you'll be able to describe the main subtypes of urinary incontinence, including why frail older people are different, and describe the initial assessment and treatment of this condition. When we think about the urinary tract and incontinence, we're usually describing problems with either the bladder or its outflow tract. Obstruction of the tract is often due to benign prostatic hyperplasia in older men and constipation, which has many causes. The result is overflow incontinence, where there is typically a constant leak of small volumes of urine. A similar pattern of incontinence can also be seen when there is reduced bladder muscle activity due to a neuronal lesion such as diabetic neuropathy. An underactive outflow tract is typically due to pelvic floor problems in older women, leading to stress incontinence where urine loss is seen on straining or positional change. An increase in bladder contractions lead to urge urinary incontinence, which is characterized by sensations of urgency, frequency, and large volumes of urine loss. This can be due to either a localized bladder disorder or an upper motor neuron disorder. However, frail older people are also frequently affected by what is termed functional incontinence. This means the difficulty accessing toileting facilities, which may be due to suboptimal environments, physical disorders affecting mobility, or cognitive issues such as disinhibition or loss of awareness. As with many conditions in frail older people, there is typically a combination of several underlying causes. Cerebral changes in frail older people such as atrophy and white matter lesions increase the risk of frailty and urinary incontinence. It should be remembered that incontinence is one of the geriatric giants, as described in a different mini-gem, and can be a way that any medical illness can present in our patients. In reality, what we typically see could be better described as underactive brain rather than overactive bladder. Given the multifactorial nature of urinary incontinence, its assessment must be by comprehensive geriatric assessment, as described in another mini-gem. A post-void bladder scan can be used to detect urinary retention. Blood tests can exclude conditions that increase urine output, such as hypercalcemia and diabetes. Urinalysis should not be used to diagnose urinary tract infection and so has little role in assessing incontinence. Urodynamic testing is rarely helpful in our patients due to the multifactorial nature of the problem and associated comorbidities, including cognitive impairment, that impair test performance. In geriatrics, it is usually a case of doing the simple, low-tech things well. The first step in treating urinary incontinence is to identify and, where possible, correct any reversible factors. Look for acute medical illnesses, but don't overdiagnose urinary tract infection. Assess for constipation, test cognition, review medications. Test functional ability and look for environmental issues. Check for fluid intake problems, such as alcohol and caffeine. Medications can precipitate urinary incontinence in a variety of ways. This slide shows a list of the type of things to be considering when assessing your patient. Reducing drugs is a key aspect of geriatrics, and your patients will often thank you for diminishing side effects and the burden of polypharmacy. Specific treatments are available for urinary incontinence, depending on the underlying cause. Pelvic floor exercises can be of benefit in stress incontinence, but not when there is significant cognitive impairment. Anticholinergic drugs have multiple side effects in frail older people and typically only small beneficial effects. Of particular concern are the increased risks of falls and cognitive impairment. They are rarely curative, and users often continue to require containment aids such as pads. For all these reasons, they are usually best avoided. Intravesical botulinum toxin can be effective but requires cystoscopy and can lead to adverse effects, including an increased rate of catheterization and urinary tract infection. Urethral sling procedures can ease stress incontinence, but being a surgical procedure requires careful patient selection. So in summary, hopefully now you'll be able to describe the main subtypes of urinary incontinence, including why frail older people are different, and describe the initial assessment and treatment of this condition. Thank you for listening.